to do hybrid. Thank you. Recording in progress. So and at this point forward, be careful what I say. This is the first scientific seminar meeting that we've tried to do hybrid. We usually do them in person, and then last year we did them remotely, all by Zoom. So this is a combination Zoom and in-person meeting. That's why I'm wearing a mask, because we got about 20 people in the audience here, and our speaker today is here in person. So we'll see how this works, and we'll be interested in y'all's feedback, both those of you in the room and those of you participating via Zoom in the days ahead, to see how this goes and how we can make tweaks on it going forward. Before I introduce today's speaker, I just want to make a few announcements. We do have the next speaker lined up, the next experimental test case for these new hybrid meetings. And it will be Dr. Bonnie Sweener, who is an associate professor in the Wilmer Eye Institute and also the director of the new Johns Hopkins Disability Health Research Center. And Bonnie will be talking to us about, in the title of her talk is Included: Advancing Health Equity for People with Disabilities. So please try to come to that in person if possible, by Zoom if that's what you prefer. And we'll look forward to hearing what Bonnie has to say. And as most of you know who come to this seminar regularly, our seminar is generously sponsored by the Matthew Tabak Memorial Lecture Fund, with also some sponsoring support from the Older Americans Independent Center and from the Epidemiology and Biostatistics of Aging Training Program. So today it's my pleasure to introduce our speaker, Dr. Suzanne Judd from the University of Alabama at Birmingham. I've known Suzanne for many years. She came to UAB before I left there about 13 years ago now. So it's a pleasure to have Suzanne here, and just really a very interesting and quite a delight to see how her career has developed over the last 15 years or so. So Suzanne got her bachelor's degree in chemical engineering from Michigan Tech up there in the Upper Peninsula of Michigan. In spite of that, she's not a Green Bay Packers fan. We did review that last night with her, and I won't disclose what team she does cheer for, but she should be a Packers fan, being from that part of the country. After she got her bachelor's degree in chemical engineering from Michigan Tech, she took a job with the Kimberly-Clark Corporation in Wisconsin and did a number of interesting things there as an engineer. She disclosed last night at dinner that the first randomized controlled trial she was ever part of was examining different features of disposable diapers for the Kimberly-Clark Corporation. After that great experience for a few years, she then moved on to Emory University in Atlanta, where she got a master's degree in epidemiology and then a PhD in nutrition and health sciences in 2008. After completing her PhD, she then came over to Birmingham and took a postdoctoral position in our Department of Biostatistics, and was really charged with breathing new life into the nutrition data that we had as part of the Regards project. And she did a great job with that, as well as other things in the Regards project. That's where I first met Suzanne. Her first office was literally right across the hall from my office, so we got to be good friends, and I ran over to her with many data-related requests, and she sort of instantly and immediately got the team on them to solve them, which was a great partnership. Like a lot of people, I think, Erica, don't listen to this part. Like a lot of people who are on two-year postdocs, Suzanne didn't finish her two-year postdoc because in this case, we realized we wanted to keep her. So George Howard, our department chair, made her a faculty position and convinced her to take it before her two-year postdoc ended. So in 2009, she joined the faculty of the Department of Biostatistics at the University of Alabama at Birmingham, and then has moved up the ranks rather quickly since then, getting promoted to associate in 2013 and to full professor in 2018. Along the way, she also found time to be an assistant dean for undergraduate education in the School of Public Health at UAB, and a Fulbright scholarship in the University de Bordeaux, I'm sure I'm not saying that correctly, in France. In 2018, Suzanne took over. She became one of the leaders of the Regards project, and in 2018, that was rightfully noted and acknowledged when she was made one of the multiple PIs of the Regards project going forward. So she has a lot of control over one of the biggest and best ongoing longitudinal epidemiological studies in the country. She also is the multiple PI in another grant that looks at the health risks specifically prominent in rural adults, and a project called Rural that is funded by the National Heart, Lung, and Blood Institute. One of the amazing things about Suzanne, and there's a lot of amazing things about her, but I'll just close my introduction with this. 2008 is when she got her PhD, so she's only 13 years post PhD. And on PubMed Central, she's an author, a co-author of over 220 database peer-reviewed publications. So she puts it out, very high quality work. She's a major player and an important leader of the Regards Project. And in spite of all that productivity and activity, she's timed to come here to Hopkins and figure out how we handle the COVID pandemic, and agreeing to be our first speaker in these sort of hybrid times. And the title of Suzanne's talk is Diet and Brain Health, State of the Science and Next Step to Address Disparities. So Suzanne, welcome. Thank you for coming, and I look forward to your talk.
Thank you, David. Thank you. Really great introduction. He's not joking. He didn't tell you the details of my first clinical trial, but literally my first clinical trial, we were trying to take the Huggies diaper that was designed to contain urine and feces in the baby. Obviously, that's what it's designed for. And we wanted to make it so you could put it in a swimming pool and the kids could swim and get around and it wouldn't blow up like a big balloon. And so what I did is I took different volumes of fluorescent pink cream corn and I pulled the baby's diaper back and I squirted it in and I calculated the rate of leakage. So we had different types of little swimmers we designed and different volumes of cream corn. And that was our randomized control trial. That was my first one. Yep.
Was that how you first got interested in diet, by studying cream corn?
You know, maybe it was. I didn't think about that, but maybe that was where it came from. So I want to kind of level set before we do too much today. I want to talk to you guys about nutrition and ask you a question, and that is, who gave you your last piece of nutrition advice? Where'd you get it from? Was it from a book? Was it from a friend? Was it from your doctor? Someone you trust in health and medicine? The interesting thing about nutrition research is that no matter what, when you talk to people, they'll tell you, I eat, therefore I know. And let me tell you, the science of nutrition and population diet is a little bit different than what you eat every day. So let's think about this a little bit in the history of dieting. One of the things I did at Emory was work with a professor in anthropology, and we wrote a book on the history of dieting. And one of the interesting people in that book were the Kellogg brothers. And I'm from actually Kalamazoo, Michigan. I know I went to Michigan Tech and I'm not a Packers fan, but to be honest with you, Green Bay is 6 hours from where I grew up and Detroit is 2 hours from where I grew up. So I'm a Lions fan, even though they never win, you know that I am still loyal. Well, the Kellogg brothers are right outside of Kalamazoo, Michigan too. And the Kellogg brothers were Seventh-day Adventists. And they really, really wanted to create the absolute perfect food because they believed that you could control your body and thereby control your mind if you had ideal nutrition. And for them, ideal nutrition was really around vegetarian food and low fat, low meat. They created this food, toasted cornflakes or flaked corn, because they thought this was the absolute perfect food that could sustain your longevity and you could function at a very, very high level. They founded the Battle Creek Sanatorium, which was designed to have famous people, very wealthy people come in, like the Fords and folks like that would come to the Battle Creek Sanatorium to gain this clarity that they were seeking. So you can see that this didn't start in 2020 with people being out there having their dietary ideas and trying to get other folks to follow them, that often famous people kind of glom onto, and that makes others want to do the same thing. So dietary recommendations, you know, they do seem to wander sometimes. I know it's very frustrating for the public to try to figure out what are the dietary recommendations that I should be following, or if you're a researcher, what are the recommendations I should be testing to see if they're actually working in the population. There are tons of agencies that recommend various dietary practices. The ones that I most commonly align myself with are from the American Heart Association and the US Department of Agriculture. The USDA is the one that when you were sitting in middle school, you learned about. It was the food guide pyramid that eventually became my plate. It's the USDA that's responsible for those recommendations. So that's where we get big governmental type recommendations. However, anybody can recommend diet. Anybody can write a book. Anybody can say you should follow this diet or that diet. They can publish a newspaper article. So there are actually a lot more folks that do wind up providing dietary advice. So if you're a clinician, if you're a dietitian, what do you tell your patients? What do you tell your patients to prevent dementia, to prevent cardiovascular disease, cancer, whatever it is you're trying to tell them to prevent, what is it that you tell them? Well, one of the things that we've really coalesced on, I think, as a scientific community are dietary patterns. We've started to talking about dietary patterns, that it's not any one component of diet, that it's multiple parts of diet that really matter. And some of the dietary patterns work actually has its origins with Ansel Keys. And some of you may have heard of him. He was a very famous physician that was really credited with being the father of cardiovascular disease epidemiology, among other things. Well, he was also in World War II. And when he was stationed in World War II, he came back and said, there's this eating pattern that's in the southern part of Italy, really right around Sicily. And that diet is very different than what I see when I'm back in Rochester, Minnesota, and businessmen in Minnesota. He described this diet that was really heavy in legumes and fish and vegetables and olive oil, and had very limited to no dairy. And he thought people looked like they were healthier on average, more fit, and lived to be longer. If you fast forward to 1995, which a lot of the Mediterranean diet work that we're going to talk about today comes to us from the studies in 1995, where the Mediterranean diet was operationalized for research. So how do you score it? How do you take these observations that Ansel Keys had, where he just said, these people look healthier, and I think I see them eating olive oil and nuts and vegetables. How do you operationalize it? And basically the operational definition became a diet that was, you got positive points for vegetables, fruits, beans, nuts, seeds, unrefined grains, olive oil. Then you got negative points for dairy and meat. That wasn't all Ansel Keys did. Ansel Keys during the war had this really specific goal, which is also interesting if we think back to the Kellogg brothers and flaked corn. His goal was to come up with a little tiny package of food that you could put in a GI's backpack. And if he got dropped in Europe somewhere, he could have 2 weeks worth of food right there on his back and not have any issues, be able to have plenty of food and make it through. So he came up with the K ration that was eventually the little package they would give to the GIs. Interestingly enough, and it's still true to this day, one of the things they gave all the GIs was cigarettes. Anybody have any idea why cigarettes? It's an appetite suppressant. So it could help the soldiers to not feel as hungry if they had a cigarette. So the cigarettes were actually included as a portion of the dietary control. One of my favorite quotes is actually from Homer Simpson, who he said it too. He only eats food in bar form because when you concentrate food, you unleash its awesome power, I'm told. That's why I'm compressing 5 pounds of spaghetti into one handy mouth-sized bar. I mean, I think that's the American way, right? Tell me what I can do so I can walk out the door with all my food in my pocket and not have to think about it again. That's kind of one of the factors that we're dealing with. So all that taken into account, that diet is complicated and that people are looking for unique solutions with diet, how do we answer questions about diet and health? How do we begin to dissect some of these really complicated questions? And in particular, how do we do that with brain health? Well, there are different levels of evidence for the role of diet and health. We've got clinical trials, and I have 2 different categories for clinical trials because there are really 2 things we can do. We can do feeding studies where we actually give people the food we want them to eat to change their diet. Those studies are incredibly expensive and can be very challenging because people have to come in and pick up the food, or we can mail the food to them. There are some new interventions where people have tried mailing food kits like what you get from HelloFresh or one of those types of food kits. But again, it involves researchers giving the food to participants so that we know what they're eating. The second type of clinical trial gives people education about what they should eat. We say, let's substitute your canola oil for olive oil. Let's add walnuts in this group and peanuts in this group, where we tell people what we want them to eat more of or eat less of, but we don't necessarily give them the food to eat more or less. We usually give good, solid interventions so that we can coach them and make sure that they're capable of following the diet, but that's more participant guided. A lot of the dietary data, believe it or not, that you've read about is actually from cross-sectional studies, where diet is assessed at the same point in time that either disease or behavior, like depression, cardiovascular disease, whatever it is you're studying, you are assessing that at the same time you ask people about their diet. And that's because the bulk of the dietary data in terms of what's published in the US comes out of the NHANES study, which is the National Health and Nutrition Examination Study. And that's a cross-sectional study where they're looking at various components of diet and many, many outcomes. It's open access. Everyone has access to the data. So that's why NHANES really guides a lot of the nutrition literature that we have. I'm actually going to talk the rest of the day about the observational study or the cohort study, which is the area that I work in the most. And even within the cohort study, so we're talking all of these levels of evidence for diet. Now we make it down to the cohort study. There are multiple ways to measure diet within a cohort study. We can do a food frequency questionnaire, which is predominantly what I do, which assesses diet over a period of time, 6 months, 1 year, whatever you ask the participant to think back to. Or you can do 24-hour recalls where a dietitian typically or someone trained would call the participant and say, tell me everything you ate over the past 24 hours and prompt the person to make sure, okay, you were at work starting at 8 o'clock. Did you eat anything in your first hour? When did you have lunch? Did you have any snacks? Trying to really get at what the person ate. Typically, we would do multiple 24-hour recalls to get a better picture of diet. There are also food diaries where we ask people to write down everything they've eaten over, say, the past week, and they keep the diet in real time so that they write down everything, and then we analyze what's in that diet record or the food diary. Each one of these has pros and cons, and we can spend some time talking about that later if you want, but for the most part, for the type of work I do, which is trying to do very large studies as cheaply as possible, the FFQ wins every day for the price tag. And most of the work that I do is within the REGARD study, which is the reasons for geographic and racial disparities in stroke. What we were trying to do with the REGARD study is break the mold about the clinic. We are trying to not have to have a centralized clinic because the research question we were trying to address is why do Southerners have more strokes than people in other parts of the nation, so-called stroke belt, and why do Black Americans have strokes at a higher rate than their white counterparts? So the only way to really get at this question was to try to find a way to break the clinic mold and try to get out into more people's houses. So we use the participant recruitment that BRFSS, which is the Behavioral Risk Factor Surveillance Study for CDC uses. So random digit dialing, where we buy telephone numbers and then we call people and try to recruit them into our cohort. We have a computer-assisted telephone interview so that the questions pop up as prompts and our interviewers can ask the person, okay, are you eligible, all the eligibility criteria, and then start asking questions about health, as you'll see in a second. We did an in-home evaluation for physical, we did blood pressure and we did ECG, and the reason we had to have an in-home component, we couldn't just do the way BRFSS does with the telephone, it's because the question, do you have undiagnosed hypertension? People don't tend to answer that question correctly. How would they know if they have undiagnosed hypertension? So we had to get in there. We had to actually get a blood pressure measure. We had to actually get some glucose measures because those were our primary variables of interest. We also have a central laboratory and repository up at the University of Vermont. They do all of our sample storage. They have a huge barn with freezer after freezer for blood sample. So all of the blood that we've now spun down, it's serum or plasma, all of the DNA, that's all warehoused up in Vermont and can be accessed for ancillary studies. We continue to follow people every 6 months, and David and other folks that have worked with us before know that you can add on various components to the exam in this 6-month follow-up. In any given 6 months, roughly 80% of our participants answer the phone. In a given year, we talk to about 90% of the participants. So we have pretty good regular contact with folks over and over again. We do blinded adjudication of our cognitive and stroke events, and also we have other events now, MI, we have sepsis, kidney disease. So we have some other events as well, but really we're funded to do stroke and cognitive events through the National Institute of Neurological Disease and Stroke. In the REGARD study, I talked a little bit about I'm getting a little bit of feedback here. We talked a little bit about the telephone interview. And in the telephone interview, there were some easy questions for us to do over the phone that didn't require in-person evaluation. For example, the demographics, whether or not the person had had a heart attack, do they smoke, how much alcohol do they drink, We could ask the SF-12 questions, and then we also asked them some questions about access to care and depression. In addition, literally 1 year after we got funded, NINDS came to us with an unfunded federal mandate that we had to assess cognitive function as well. We had no idea how you do that over the telephone. Nobody had done that yet. It was something that we had to bring in some folks. Virginia Wadley from gerontology at UAB came in, and she said, sure, we can figure out how to take the MoCA and a couple of these batteries, and we'll try it on the phone and we'll see what happens, which has really turned out to be very, very helpful for us in the long term. For the in-home visit, we contracted with the very same people that come into your home when you have a life insurance visit. So when you call and you want life insurance, you know, they say, well, sure, we'll give you life insurance, but we're sending somebody to your home to make sure you're not about to drop dead. They draw your blood, they get your blood pressure. Sometimes they do an EKG. We wanted them to do an EKG and they had the capacity. And then they can do all other kinds of services as well. We had in our first round, when we recruited 30,000 people, we had over 6,700 technicians that we had to get IRB approval for because they were named people on the study. We had to train them on the IRB, on HIPAA, how to appropriately conduct research visits. And it was a challenge. We also had to make sure they did our protocol correctly. So that was one of the biggest challenges. How do you manage all of these clinicians that are doing the visit for you, these technicians? In that in-home visit, they also had to do informed consent, which is why they had to do understand the IRB process and get covered on the human subjects protocol. They did height, weight, and waist circumference. They got blood pressure, the ECG, as we mentioned. They drew blood, collected urine, and overnighted those samples up to Vermont. And they recorded all the medications that the participants brought to us. So we asked them to bring all their pill vials and lay them out. They also handed over the questionnaires, the self-administered questionnaires for the participant to complete and mail back to us. Like I said, we've got our 6-month goals where we look for incident stroke, MI, we do cognitive assessments, and then we send it off to the clinicians for adjudication to verify what we actually have. In terms of cognitive function, those of you that are wondering what we have, every year we ask the 6-item screener that just to have a regular check on the 6-item screener. And then every 2 years, we ask the NINDS brief protocol, which includes wordless learning, animal naming, and letter F fluency, and a modified MoCA. So at the end of the day, this is what we had. Our goal was to recruit 30,000 people across the United States. We wanted it to be half Black American, half white American, half male, half female, half from the stroke belt, which is the 8 states other than Florida that kind of make up the Southeast, and then half from the rest of the nation, all in the lower 48. In this map, you can see the geographic distribution of participants. They're very spread out for the most part, but you can see they do concentrate in cities, which makes sense because it is a random sample. You would expect it to be roughly randomly reflective of the US population, and more Americans live in cities. Although we do have over 3,000 rural participants that are actually living in areas defined as rural by the RUCA codes. We're going to spend most of today talking about dietary intake and talking about how I've used the dietary data. For the diet, we had the Block 98 food frequency questionnaire. We called around and asked several folks, which one do you think we should use? This was the only one that had been validated in a cohort, the age that our cohort was going to be, that had large numbers of Black Americans. So we thought this was the one that was going to be best for us. It was self-administered. So the participants filled it out themselves with some coding so they could understand how big a serving size was. We had a few pictures. And then they mailed it back to the coordinating center. After that, we scanned it into a computer using an optimal or character recognition so that it actually could see the boxes that were checked, which was another big challenge because it did not always work the way it was supposed to. And then we sent that data to Nutrition Quest, which is Block Dietary Systems, for analysis. If you look at the number of people that gave us dietary data back, if we had 30,239 were given the FFQ, about 25,000 of them returned the FFQ, but only about 21,500 had usable data. A lot of folks, you can see here roughly 4,000, they just mailed back blank FFQs. Has anybody here filled out a food frequency questionnaire? Larry, you're going to be my only guess, but they're long. This is an 8-page questionnaire, 108 items. It's intense. And You have to check for each item how often you eat the food, and that can become stressful because, oh, I don't know if I eat it weekly or twice a week. I don't know, I'm not sure. And it just, people can start to get stressed by the end, and then they say, forget it, I'm not done, or I'm not finishing it. Well, we took all of that data that came in off those food frequency questionnaires, and we created dietary patterns because that's what was of most interest to us. Again, starting with that Mediterranean diet that we talked about a second ago. You'll see these are the exact same components if you take a second to look at the first bullet that we had talked about in one of the earlier slides. We created the score by standardizing the values by sex so that the people were assigned a point at the median. And then we took away a point for those that were consuming above the median for meat or dairy. What that leaves you with is a score that ranges from 0 to 9, where people could have, 0 components where they were above the median, or all the way up to 9 components above the median. We split it into tertiles, rough tertiles. And again, you can see that these numbers here are going to add up to closer to that 21,000 number versus, yeah.
Yeah, just go back to the prior slide.
Sure.
Previously, you said that if the Mediterranean diet, the issue about dairy is always comes up.
Yeah.
But it seems like you said it was, Anthony said it was low in dairy, and yet you include it here as number 7.
Yep, they get a negative, they lose a point.
They lose a point
Yep.
for dairy.
Yep.
That's actually, some people believe it.
I know, it's so you're exactly right. When I got to France, they were that's the biggest sticking point they had because they thought dairy should be in the plus category.
The other one is movements, I guess olive oil, but in terms of the healthy diet, people think it's
Yep. Yep. We only used MUFAs because we didn't have PUFAs from Block, but we do now. We did not when we originally created it. We should probably go back and see how much that changes the score. Yep.
One more quick.
Yeah, please do.
Does meat include poultry?
It did not. It was red meat.
Yeah. So
Specific-
Sort of poultry, sort of
It-
neither of them.
Exactly. It didn't get either. Yep. So you can take a look here and digest this slide to see which participants were in the highest tertile of Mediterranean diet versus those that were in the lowest tertile, consuming the least likely to adhere to a Mediterranean-ish diet. Although the use of the word Mediterranean diet is always questionable. Again, remember, this is within our sample, people who were above the median for the various intakes. This is probably not even close to a real Mediterranean diet. It's just those who were a little bit closer than the rest of the people in the cohort. And you can see that in general that there were very few differences across the tertiles. Anything that would come to the level of being concerning where you might say, oh, I see something right away. It was pretty well spread out other than by region. There are slight regional differences here in terms of consumption of the Mediterranean diet. We then wanted to see if it was associated with incident stroke. This is one of the first dietary patterns papers that we wrote in regards. And you can see that after you adjust for age, race, and the age-race interaction, I'm not going to spend a ton of time talking about stroke epidemiology, but I'll tell you that there's a really strong age-race interaction that you always have to account for, because Black Americans, they are far more likely to have strokes at younger ages than their white counterparts. So adjusting for age race, that age race interaction, you can see that the hazard ratio is protective from incident stroke, 0.76, and it's statistically significant. That holds after you throw the kitchen sink in there. So you name it: education, energy, smoking, waist circumference, hypertension medication use, anything you can throw in there, and you've still got this association where the Mediterranean diet score, when you compare the low to the high, is protective from in terms of developing incident stroke. And these are only incident ischemic strokes. For the most part, in regards, we pull out the hemorrhages and they're treated separately. We did a very similar analysis with cognitive function. The cognitive function analysis, this is just the 6-item screener. So looking at people that become impaired on the 6-item screener, because again, it was early in regards, we hadn't coded all of the expanded battery that we have at this point in time. What was really interesting with the cognitive measure was that there was a strong interaction with diabetes. And so in this particular analysis, you can see that protective effect from incident cognitive impairment is only present in people that did not have diabetes. It was not something we were looking for a priori. This was actually something that a reviewer requested after we sent it out for publication. And because basically when we first sent it there, it was protective across the board, across the entire cohort. But the reviewer really wanted us to test the interaction with diabetes. And like I said, it wasn't our a priori hypothesis, but you can see it is strong and it was significant. So what do we know? We talked a little bit about clinical trials. The PREDIMED study is a clinical trial where they actually tested the impact of the Mediterranean diet using the method where you tell people what to eat, where you tell them what you think they should eat, and they're randomized to each of those dietary patterns. There were 3 patterns with PREDIMED: a control diet, or some people argue the intent to harm arm, because people say that they took people that were eating relatively healthfully and then asked them to take out olive oil and nuts, but I'm not actually totally sure that that's true. There were the other 2 groups that were given a diet where they were asked to consume up to 1 liter of extra virgin olive oil or 30 grams of nuts, walnuts, hazelnuts, almonds per day. All group experienced reduction in blood pressure, but the Mediterranean diet group had the biggest drop in blood pressure. They also saw big differences with stroke in the PREDIMED trial. It was associated with a decreased risk of stroke if you used an intention to treat analysis. So this is another indication with the clinical trial that we're seeing some decreases in terms of stroke risk with a Mediterranean diet. There was a very small nutrient gene interaction trial with the PREDIMED study where they were looking at a very specific polymorphism that's associated with lower triglycerides. And some of you that are genetic epidemiologists may know this polymorphism. Here they observed a diet gene interaction where the association was strongest. And if you combined those nut and olive oil groups together, it was strongest in the folks that had the polymorphism. So this is another one of those studies that I really find interesting because I don't do any work with genetics. I just talk about diet as if it applies to everyone. But there are a few studies that have found that there are some of these genes that might actually, you might see differences in dietary patterns based on the gene. Yeah.
I think you said, but I just want to make sure, you say a liter of olive oil a day?
A week, sorry. Which is still, that's a lot of olive oil. Yeah. They weren't hitting a liter a week. They were not. Right. They were randomized at the family level. Yep. So this is actually where David and I come to be, where we started working together. One of the things that was very popular when I was getting my PhD was to use factor analysis to create dietary patterns that didn't force you to put a label on healthy. And I've only talked about Mediterranean diet now because there are so many out there. We were just talking about the dietary inflammation index earlier. But this approach allows you to say, I'm not going to decide what's healthy. I'm just going to see what people are eating together, what types of foods people are eating together. So we started with those 108 items from the food frequency questionnaire, and we reduced it down to 56 food groups. We originally started with 58, but we had a couple of food groups that just had 0 loading. People weren't eating them, so we had to get rid of them. The food groups that had very high 0 values, the diet shakes and the breakfast bars, we wound up the diet shakes were eliminated altogether, and then breakfast bars we tossed into sweetened breakfast foods. From here, we split the sample in 2, and this was why it was great to have psychology, someone trained in psychology on the paper, because a lot of folks will just throw these patterns into a model and see what patterns are spit out. But we actually split it in half. We did a factor analysis on the first half of the sample, and we looked at multiple different cutoffs. The eigenvalues would have allowed us to retain 6 factors. So we could have actually retained 6. But as we went through to figure out which made sense in terms of fit, we looked at a 6, a 5, a 4, a 3, and a 2-factor solution. The 5-factor solution was the one that made the most sense because we could get congruence across race, region, and sex. And that was very important to us. We used confirmatory factor analysis on the second half of the sample to validate what we derived in the first half of the sample. and we had sufficient fit there. That left us with these 5 factors that we then applied to the whole entire cohort. And I'm going to put these up here for a second and let you take a look at them, but not there. There we go. So you can kind of see what's in each factor. If you started out with factor 1, and just to give you a feel for what we were working with, prior to our work, most studies had only found 2 factors, which is what we were hoping for. 2 factors, healthy and not healthy. That's what we wanted. We couldn't come up with a 2-factor solution. It just didn't make sense for our data. So if you start looking at this and you looked at factor 1 and you looked at factor 2, you might say, okay, the first factor, that's going to be your Western or your unhealthy style. And your factor 2, that's going to be your prudent or your healthy style. But then you look at factor 3 and you see factor 3 with a lot of sugar, a lot of desserts and bread and chocolate and sweetened breakfast foods and margarine. And you say, oh, that might not be, that kind of sounds like a Western diet pattern too. And then you look at factor 4 and you see fried foods and organ meats and processed meat and eggs and added sugar again. And now that kind of looks like the Western or the classically unhealthy. And then you get to factor 5 and it's salads and wine and salad dressing and eggs. And you think, oh my goodness, what is going on here? What are these factors representing? Lots of people, when they've given this talk before, they'll joke that factor 5 sounds like a faculty diet because it's salads and alcohol and coffee. It's tough to say, but I think one of the things that Regards allowed us to do was having 30,000 people that were recruited from their homes. It gave us a huge cross-section of socioeconomic statuses. And what I think we're really able to look at with these data, we're able to look at different less than healthy diets that might be eaten in different strata of the population. And someday I want to find a graduate student to go back and redo this analysis, but look for congruence by education and income, because that's where I think we're going to see that these patterns aren't congruent. But all that to say, the hard part when you do this type of factor analysis is you have to name these patterns, because readers don't want to read factor 1, factor 2, factor 3. And I'm not, David, tell them I'm not lying. We probably had 10 to 15 hours of meetings on what to name these patterns. It was painful, really painful to figure out what we were going to name all of these patterns.
Can I say something about
Yep.
that?
Yeah.
So, I mean, I'm looking at these, so red meat appears 3 times. I would love to be in factor 1, but my wife makes me be in factor 2 all the time. But when I look at red meat, the loading on factor 1 is 0.44, and then it's like 0.25 over on factor 4 and something similar at the where it is on factor 5.
Yep.
So I guess why did you retain red meat for factors 4 and 5 versus just shoving it into factor 1? Was it the 0.2 cutoff that was your hard cutoff?
That's my hard cutoff for showing on this screen.
Okay.
But no, all 56 components are in all of the patterns.
Okay.
And we used an orthogonal rotation. So all factors are independent of one another. So you can have, that's why red meat can appear across all the dietary patterns.
Okay.
Well, that's for the first sample. We have to go back and check the details of what the second sample. We did fix a lot of loadings to be 0 when we confirmed it with the.
Mhm.
I think we sort of kept everything that was 0.20 and allowed for split loadings. Yes.
Yeah, I think we kept everything, but maybe it was only 0.2 and above. I know we only ever show 0.2 here because I've got an Excel spreadsheet that's got all the loadings if you ever want to see them. So this is what we came up with the final namings. There are these 5 patterns. The first one really looked a lot like people who were eating out. It was pizza and it was Mexican food and Chinese food, mixed dishes. So we thought this was probably folks that were having to eat out a lot. So we called it convenience. The second we called plant-based because we really didn't want to call it healthy. We didn't want to put the label of healthy on it. So we called it plant-based, but it does have fish and poultry. It's just that this was the pattern that had the highest loadings of vegetables. We called the middle pattern sweets because there were tons of, every sweetened category we had was in this particular factor. The fourth one, and probably the hardest one to name, we eventually named Southern, and we named it Southern because It was more commonly consumed in the southeastern part of the United States than other parts of the country. And it was similar to what folks might think of when they think of Southern dietary culinary pattern. This is the one, if I could change any name, this is the one I would change. I don't know what I would call it today, but I think that the fact that we called it Southern leads to judgment when it's used. When it's used in research, I think there's a judgment that gets put on there. And so I really wish we had not used Southern, but that's the one we're stuck with. The last one we call alcohol/salads because it's got all the alcohols, beer, wine, and liquor. And then you've got these green leafy vegetables and salad dressing and nuts and seeds and protein and coffee. So we called it the alcohol salads pattern. So what about stroke? Because again, that's our bread and butter in regards to stroke. And we wanted to see whether or not each of these patterns was associated with stroke. Convenience pattern was not, neither was the sweets and fats pattern, nor was the alcohol salads pattern. It was just the plant-based and the Southern dietary pattern. You can see the plant-based is slightly protective of stroke here in the last quartile. The higher the score, the more likely someone is adhering to the plant-based factor. Very similar to what we saw in the Mediterranean diet in terms of the strength of association of that point estimate. The next one is the Southern dietary pattern. And this was the first paper where we really saw the Southern dietary pattern having a strong association with something. And this is the stroke paper again. We've now gone on and we've looked at this with heart disease, with sudden cardiac death, with kidney disease, end-stage renal disease, with sepsis. And of all the dietary patterns we have, this is the one that over and over again is associated with an outcome.
Can I ask a question?
Yeah.
In terms of, I know you are talking different ways to do models, but some of those look like really over adjustments and, diet and income and education. I just don't, not that I go straight to the bottom and say that's the best model.
Yeah, I
What
agree.
is the model that you think best reflects diet? Because I think it might be the one with adds education, but adds energy.
Oh, yeah.
Yeah.
So just starting with adds energy rather than a lot of the demographic factors.
Well,
Yeah.
yeah, well, I assume that it's including the age, race.
Mhm.
Well, but I don't know if it's hierarchical or what. but
It is hierarchical.
It is hierarchical.
Yeah, yeah.
But the income and education is not something I would put in because I think that that's really highly associated. I know you have to show that.
No, I think you're right. I think that actually is very true. It is highly associated with diet. That I actually think it goes beyond just being associated, and it may complicate this particular dietary factor. So that's a good point. I would agree. Probably energy should have gone after the age, race, sex, age, race interaction. Mm-hmm. More importantly, and you're going to hear a lot about this in the next few slides, is that this dietary pattern completely mediated the black-white difference in stroke. The 1.12 was no longer statistically significant. So the 1.38 is the hazard ratio for race with stroke. And we put in that Southern dietary pattern and it comes down to 1.2. Prior to this dietary analysis, we had not done a single analysis where we could identify a risk factor that mediated the black-white difference in stroke, that took it down to the point that it was no longer significant. 65 and older, there is not a black-white difference in stroke in regards in people over 65, so there's not much going on there. And there wasn't much going on in region, to be honest with you. We have not been able to identify regional differences in stroke really in regards either. They're very, very small when we look at incident stroke. So now let's jump to hypertension.
So the stroke belt is a misnomer, you think?
Is George here? George Howard, because I'm gonna have to duck. He might throw a rotten tomato at me. I do think it might be a misnomer. I think there are things in the stroke belt that you can't fully adjust for when you look at stroke mortality. I don't think you can fully adjust for the racial difference in stroke. And so that becomes complicated when you're looking at the differences. There's also other parts of the country like Oregon and Washington that have surprisingly high rates of stroke as well. So yeah, I do wonder about the stroke belt and whether or not that may be a misnomer. But this certainly has unadjusted, the stroke living in the Southeast puts you at greater risk of stroke, unadjusted for multiple other factors. So in our study, we then went on to look at incident hypertension because I'll take a step back. we identified that hypertension was a big risk factor, particularly for young folks, in terms of the racial disparity in stroke. It didn't mediate it all away, but it was pretty strong. So we went back and we got a second in-home visit. We went back into their homes 10 years later. And we found out that of people that were free from hypertension at baseline, about 49% of the Black Americans in our study versus 35% of the white Americans developed hypertension after 10 years. So here you can see that racial disparity again, now moving into hypertension. This is just the mediation analysis for hypertension. Try the papers in JAMA, you can take a look at it. There are many factors in there besides diet, but again, we're just focusing on diet today. The biggest mediator of the Black-white difference in hypertension was, again, this Southern diet score. It mediated 52% of that Black-white disparity in hypertension. That was in men. In women, it mediated 26% of the disparity in hypertension. So this particular diet pattern has had this very, very strong association with, and also the potential to mediate away the racial difference in stroke and hypertension. So what does that mean? Like I said, it's the most potent mediator. What does it mean to be a potent mediator? That's one of the things that we're really trying to figure out. George Howard and I have totally different opinions on this particular topic. George thinks we should randomize everybody and get them off the Southern diet pattern. I think the Southern diet pattern probably codes for the impacts of structural racism better than are you Black or white. I think that this dietary measure is probably something that is more strongly related to income and education and factors that we just don't do a great job assessing. But George loves to tell me not to let the data get in the way of my opinion, because that's something I've yet to prove. It's just something I think right now. Do we want to say something? No. I want to throw these factors back up there again so you can see what they are. Why do I think that there's something more going on with factor 4? Well, if you look at factor 3, that should not be a healthy dietary pattern. That should not be something that's associated with positive outcomes, but it's on the edge of being protective from stroke risk. It's on the edge of being protective in cardiovascular disease. And so I just think there's something going on where factor 3 and 4 are teasing out unhealthy diets in a way that's not as easy to understand as the data first show us. And I would love to have any thoughts or ideas about what we could do here. I think the first step is to redo the factor analysis and look for congruence by income and education. That's what I think is the first step. But it is fascinating, and it's to George's credit that factor 4, if you put it in an analysis, we can pretty much wipe out Black-white differences in outcomes. Yeah.
So you're just dealing with the FFQ right here, and you're not contaminating it with any other types of data. But you have, you said earlier urine, because I just I'm not double tasking, I was actually checking to see if you
Yeah.
potassium, and you do have that. So because I quite frankly think that factor 4 could be a surrogate potentially for lower potassium.
You're right, it might.
And I don't know about factor 3, but did you consider including? I mean, I know it's not part of the FFQ.
Yeah, we have not measured urinary potassium or sodium yet. That's one of the things that we've talked about getting.
I
But
thought your FFQ, was that from your FFQ or?
it was from the FFQ.
Oh, okay. So
Yeah.
it wasn't from the urine.
Unfortunately, no. It's one of the things I'd love to get funded, because I think that would be add a ton to the data. So what about other countries? We talked about Predimed a minute ago. The one thing I didn't mention was that Predimed also demonstrated that dietary pattern, the folks that were randomized to olive oil or nuts, the Mediterranean style, they had a lower risk of MCI, dementia, and improved MMSE scores, although they didn't measure it at baseline. So this is just really, after 6 years of follow-up, they saw lower rates of dementia, MCI, and higher MMSE scores. The other cohort I'm going to talk about quickly here at the end is the 3C cohort, which also examined a Mediterranean diet score in the Bordeaux population and looked at, found that higher adherence to this Mediterranean diet was associated with slower MMSE cognitive decline, but was not associated with incident dementia. And so I reached out to colleagues there and said, hey, I'd love to come and do a Fulbright with you and see if we can take a look at the dietary data we have in regards and the dietary data we have in at 3C and see if we can find something happening there. And they were wonderful. They said, oh yeah, come on over. We'd love to have you. I actually spent 6 months in Bordeaux working alongside the epidemiologists and statisticians there, and learning about their data. Because the 3C study is very similar to Regards in some ways. It's 10,000 people across the 3 cities of Dijon and Bordeaux and Montpellier. It started in 1999. We started in 2003. So again, very similar from a time period. They have all of the same measures in terms of traditional risk factors. And they've done a great job assessing their endpoints like dementia. We don't really have dementia in Regards yet. We have cognitive function. We can look at changes in cognitive function, but we don't have actual dementia yet. We're still working on collecting that one. So when I got there, and they'd already published the Mediterranean diet paper, and it was funny, I sat down with the lead neurologist from the study, and he said, why do you come here to study diet? I don't understand. The French, we have excellent diets. You're not going to find anything. There are no differences in diet in France because we all eat the way we're supposed to eat, unlike you Americans. And I said, oh, okay, well, then I guess I won't have much to do for 6 months. I'll just sit here and, hang out with everybody. So we took a look at it and tried to figure out what was different. Bordeaux has a much more elaborate food frequency questionnaire than the rest of the 3 cities. But all of the cities were asked a very brief screener for diet. And their very brief screener included raw fruits and vegetables, cooked fruits and vegetables, fish, olive oil, legumes. And so we decided we'd give a point to everybody if they consumed each one of those things so that they could have a total possible score of 6 points. There were also a few other things like red meat that we didn't include in the score. Red wine, we originally were going to include wine in the score. It turned out 95% of the population reported drinking red wine, so it was not a very useful measure to add in the score. And then we followed the folks up to look for dementia and stroke. If you look at the dietary score, the first thing I did, because this was kind of a score that we were working on, it didn't have a lot of basis in science. We were just trying to use the data we had. So I was worried about, would there be any kind of distribution to look at? We did see a nice distribution with it, kind of centered around 3 with this dietary score. So that was promising as we continue to move forward. Looking at the descriptive statistics here, splitting it into low score, the mid score of 3, and the high score of 4 to 6, you can see that there are some slight differences by age, also slight differences by income, with the people in the highest group, the high score, which would be considered the most closely following dietary recommendations, having greater income and greater education. The percent that graduated primary school is that education variable. You can also see there were some differences in terms of smoking. The folks in the higher score group were less likely to report smoking, which was also kind of funny, 8%. These are very low rates of smoking versus what I thought I observed. But, again, that's just observational data from my own eyes. When we go to look at stroke, the interesting thing about this score was it was protective of stroke. If we put the score in the model, you can see that first line, which is adjusted for age, sex, education, income, hypertension, AFib, diabetes, dyslipidemia, BMI, and smoking, that it is associated with a decreased risk of stroke. We don't have energy for this particular analysis because they don't have total energy for all people in the cohort. It was interesting. I went back to the neurologist and I said, well, I don't know what it means. It might not mean diet, but it does mean that something is going on here. Oh, I forgot to mention too, we were also going to put dairy in here and give negative points for dairy, which was that one conversation I was telling you was quite the fight around the table. But just like red wine, 95% of the population reported consuming dairy. So there just wasn't enough distribution with dairy. This is the spline analysis that shows the same thing if we were looking at the score as a continuous variable, and you see that as the dietary score increases, we just see a decreased risk of stroke kind of across each of the points that we assigned. So what about dementia? The next question was whether or not this diet score was associated with dementia. And we found, similar to stroke, that this score was associated with reduced risk of dementia. So again, similar to the spline that you saw a second ago, this was an exciting finding for me because I spent a lot of my time thinking about how you reduce diet down to a simple score that you can throw in the model. We also stratified the dementia results. These were the ones that the neurologist really did not believe. He said that there was no way diet was associated with dementia and I had done something wrong. And so we tried to find a way to get rid of the association. We tried to look by age, we tried to look by income, by whether or not there'd been a previous stroke, and the results were amazingly robust, all in the same direction of association. It's not like any one of these stratifying factors would explain away the association. We also tested for interaction with gender and ApoE4, income, education. All of them were P greater than 0.05. So, you know, again, this was a very robust analysis that held up and indicated that this particular dietary score was fairly strong in terms of stroke and dementia risk. So overall, we've been through a couple of different cohorts in 2 different countries, in France and the United States. We've looked at all these different dietary patterns and multiple outcomes, and diet was there every single time. Now, I can't tell you that it was the broccoli or the olive oil or any one component, which is what, you know, everybody wants to go back to Homer Simpson and they want to have that, what's the one thing I'm supposed to do? I can't tell you what the one thing is. But I can tell you that if you look at diet across various cohorts, whatever it's coding for, it matters. It matters. And that's the one thing I would want to leave you with here, is that if you're doing a longitudinal study and you can find a way to get your funder to measure diet, do it. It matters. It may change the findings. You may find the mediation finding that we see in regards. Diet really does matter. So please measure it. And that's it. That's all I have for you today.
Okay, Brian, are you still here? Oh, there you are. Why don't you send a chat to our online people and ask them to ping you if they want to ask a question. And in the meantime, those of us here in the audience, questions for Suzanne.
Yeah.
In regards, when you were assigning scores for the kind of foods the individuals eat, did you give a negative score for consumption of wine, or did you give a positive score?
So in regards, when we did the Mediterranean diet analysis, we gave a positive score for the consumption of wine. In the factor analysis, it was tossed into the model. It could be negative or it could be positive. There are some of those factors where wine loads negatively.
So irrespective of quantity, so you need like.
Yeah, that's right. That's right. Yeah.
If you're worried about differences in the score by like income or SES, have you stratified the sample and rerun your models within those subgroups?
We've done stratified analyses where we look at what's the association of that factor 4 with stroke in high income and low income. We've done that, but what we haven't done is recalculate the score. If we were to rerun the factor analysis just in high income, just in low income, would we be able to produce congruent dietary patterns? That's the piece we haven't done. And that's where I suspect, I don't think we would be able to. But again, just haven't done it yet. Yeah.
So when you were doing the Mediterranean, I mean, giving scores for people, you said that if they consumed like olive oil above the median, then they get a 1. Is that median like number of servings in a week, or is it percentage of calories that it's coming from?
It's number of servings in a week. That's exactly right. And it's so it's the median for our cohort, that 30,000 people, really 21,000 people that had dietary data, so that you just have to be consuming more than the people in the cohort, which does not even come close to a high consumption of olive oil. Might or might not.
So if you're like maybe a smaller person in that cohort, you might not just consume as much calories. Right?
That's right, because we didn't do any residual energy adjustment. We just did straight intake. Mm-hmm. Yeah.
Really fascinating talk. 2 comments and the discussion about future. Just one thing is that there is a clinical trial, the MIND trial, actually.
Yeah.
And I think the study trial is finished. I don't know.
I've heard rumors it's finished too, but I haven't seen the results.
Yeah,
Okay.
Yeah, but it should have results and they tested the diet that was sort of a hybrid of the action and that. But getting back to sodium potassium is one of my favorite.
Yeah.
You probably heard about the trial called SAS, which
Yeah,
And I think that, blacks tend to have lower potassium excretion, higher sodium. They also, and for many reasons, I think would be, good candidates for a trial of a salt substitute. And salt substitute studies have not been done in the US for the most part. It's been done mostly in Asia.
Yeah.
and other places, but it might be a direction to go, and further support actually, your early question.
Yeah.
That we don't have young analyze the urine. I think your spot urines are suboptimal by themselves. A large number of people, I think they could be, give a signal and help justify
yeah, that's a great idea. That's a really great idea. That's, so how, if we were to give us a high potassium salt, can that overcome the sodium that they're getting in the processed food from the regular diet, or?
This is tricky because in China, most of the salt comes from discretionary rather than processed.
Okay.
In the US, most of it is processed and supposed to be discretionary. Still, a lot of people consume it. Though. It'll take a fair amount of work to figure out, but I think that trial is one of the only trial I'm aware of where dietary intervention, population based is to a reduction in the heart outcome.
Yeah.
So it's really
Okay. Okay, that's a great suggestion. Yeah.
Thank you. It's a great talk. I keep thinking about your factor analysis. And so the factor analysis really identifies food consumption types that tend to go together. So it's really sub-patterns.
Yep.
Right? And so if you wanted to get the overall pattern for a person, it would be a combination, right? It would be the weights times the factors. And so, for example, I'm probably high on factors 1, 2, and 3.
Mhm.
So have you looked at interactions?
We
among
have
the
not.
scores?
We've talked about how you might look at interactions. We've come up with a lot of really bad ideas. But that is one of the things, because we thought maybe you take like the top quartile, and if you're in the top quartile of a couple, or directly test the interaction, but no, we have not yet done that.
Yeah, absolutely, because I'm thinking about that sweets factor. And
Yeah.
I imagine there's people like me who have sweets a lot, but it's a little bit in combination with salad and fish.
Yep,
Versus people who just load up on sweets while they're loading up on something else.
absolutely.
Would you recommend like a latent class analysis instead?
That's the way that I would think of it for patterns, but it would be very unwieldy because of the number of items. I wouldn't know how to do it
Well, you
rationally.
meet tens of thousands of people,
Yeah,
which you have.
yeah,
It would be another approach to thinking.
yeah. Yeah, thank you. That's a great point.
I think just to clarify this, as I recall, so we use the factor analysis to identify patterns, but then we got a score of each person in terms of their amount of consumption of these different foods and these different patterns. So-
Absolutely.
Yep.
But
So
then
we didn't classify
my,
people into groups, we
right,
classified diets into groups to get scores.
exactly, yeah, that's right.
Yeah. The other funny thing, I was just looking at Alden, and he reminded me of this earlier. So when I started with the Mediterranean diet, it's what I really wanted to study in Bordeaux. And I went there and I was talking to people about it. And one of the postdocs looked at me and said, "You do know Bordeaux's on the Atlantic Ocean and not the Mediterranean, right?" It's like, yes, I do. I said, I don't know why we call it the Mediterranean diet. I think it took hold after Ansel Keys. I think it got exciting, and so we studied it, but that's why I like it better when we kind of focus on what components are in there rather than assigning it to a region, because it's not necessarily regional. It's not everyone in the Mediterranean eats that way. And it is kind of silly when you talk about applying the Mediterranean diet to a city that's on the Atlantic Ocean.
Just to follow up on that, I spoke to one of the investigators in the 7-country study that's where.
Yeah.
He said, besides diet, one thing about Crete, which is where they.
Yep.
Really one of the most striking associations, but they're very physical.
Yes.
Very physical.
Yes.
Like climbing trees to get the olives, that kind of stuff.
Yep.
There probably are some big confounders with it.
And that's one thing in regards, we have a physical activity measured well on a small subset, but not on everybody. And that our physical activity question, we were talking about that earlier, is how many days a week do you exercise enough to work up a sweat at least 30 minutes? So we only wanted one question. We went to the physical activity researchers and said, if you can give us one question, what question would it be? And that was the one they came up with, but it's not the IPAC, and we have accelerometers on about 7,000 people. But that question just doesn't correlate with anything. And I just think it's because it's just the one question.
I mean, you just don't, not too many people do that.
Yeah. Yeah. Yeah.
So thank you for a great talk.
You bet.
I was just curious about data collection because I know there's all these apps out for tracking your food intake and calories and all that kind of stuff. So I know you're using the FFQ, but I was just curious if you started using any different technologies and things that are useful for research.
We have not yet started doing that, and I don't think we will. We're trying to do a third in-home visit in regards. I think we'll still just go with an FFQ on this in this particular cohort, but I have another cohort where the Framingham Heart Study in regards kind of got together, and we're having a cohort where we're going into 10 counties in the rural South with a mobile clinic, and we're doing a much more comprehensive assessment than the 45-minute in-home visit that Regards did. And on that one, we've been trying to figure out what's the dietary ancillary study that we want to write. And that's something, any of you that are really interested in diet and want to get in on the ground floor, I'm looking for investigators to write the dietary ancillary study to rural. And that's one of the things we've talked about. We can use, there are some really cool programs where they just take a picture of their food and it does all the dietary analysis. That would be great.
Brian, and any of our online people have any questions?
Not yet. I'll do a little thing here.
Give them a 2-minute warning. I'll ask a question.
Sure.
As a psychologist. So, and I think this is true really across the age span, but especially of older adults, diet is partly, maybe even largely dominated by kind of social structure. If you're married or single, if you're single, you're eating out more, and there's a. And in all your covariates you listed, there might have been marital status or something.
Yeah.
Once in a while, but can you comment about to what extent you controlled or?
We did not. That's an interesting question. Yeah, we have not controlled for, so especially we did not put marriage in there at all. So that might be something else we want to consider going forward. We have other measures of social support and social isolation as well that may be interesting measures to consider, especially as they're associated with the dietary pattern itself. We could go back and take a look at some of those things, but we haven't dug into those data like we should.
And refresh my memory. I mean, you mentioned that we had lots of conference calls with our co-investigators and naming those factors. Factor 1 is clearly the closest we got to the Mediterranean diet, and I think at one point it was on the table.
Oh, factor 2, it was, yeah, yep.
But we decided not to, maybe because it didn't have all the components, or maybe because of other reasons.
I can't remember. That was another, the number 4 and number 2 were the biggest fight. 2 was the one we eventually named plant-based. But yeah, we talked about calling it.
Yeah, that one, I think we thought about calling that one.
We did. But we chose not to call it Mediterranean. It was tough. Naming those patterns was tough. It's one of the toughest things that we did. Now we're stuck with it. And it makes, I'm telling you, journals love when the Southern, they see it because they know they can sell it to the New York Times, and everybody else is going to jump on it and want to publish on it, which is why I kind of hate that we did that. Wish we'd called it something else. I think if it would have been something like a high fried food or something, I don't know that it would have been as jazzy. It still would have been jazzy, probably. Fried food kills you. That's a great headline that people would love to publish. But I always, when I'm talking to folks about it, say, well, all it means is that people that have a high score, they probably eat fried food every day. People that have a low score probably eat it once a month, but it doesn't mean they don't eat it, at least in our data set. Even the low consumers are consuming it occasionally.
So watch your fried foods, but desserts are okay
According to this, although that's my other piece of advice would be never take dietary recommendations from a cohort study. That is what clinical trials are for. Cohort studies just start the process of taking a look at it. But I think it can get dangerous if we start making dietary recommendations based on on cohort studies. I don't know. Feel free to disagree with me on that. But what was that?
Nobody's funding keeping studies.
You're right. Yeah, nobody's funding them.
We have a question that's come through the chat.
Oh, good.
We have a little report. So one of our EBA fellows, Carly's asked, do you have data on where the participants are from? And if so, do any analysis looking at whether those who fit best to the Southern diet were mainly from the South or not?
Yeah, absolutely. We do have data on where people are from. Not only do we know where they're from, we know where they've lived everywhere since they were born. We have residential history data, self-reported up until our baseline visit. But yep, we know right where they live. We've geocoded it down to the block group level. And folks that lived in the South were more likely to consume the Southern pattern. That was how it eventually got its name. I think something like 60-some% had the highest, were in the highest upper quintile.
Okay, well, I guess we'll, I don't know if anyone can see me, but thank you.
Oh, yeah, you need to stand here.
Thank you all, for those of you who joined us remotely. Brian, do you see any more questions from our remote audience? Okay, so I think we'll wrap it up then. This has, I think, been a success for our hybrid session. I thank all of you for showing up in person and those of you signing on online. 1 month from now, 4 weeks from now, it'll be Bonnie Sweener talking about disparities in disability. So I'm sure that'll be a great talk as well. Thanks, everyone.
Thanks.